What I'm going to talk to you about next is this concept of MAC. And MAC is a brilliant concept. It's a little bit hard for the student to understand initially, but once you sort of understand it, it makes gases very easy to use. So the key points we're going to talk about is what exactly is MAC. Then we'll go over what are the MAC values for inhalational agents. Then we'll talk about what are the things that affect MAC and how do you add MAC. What's called MAC bar and what's MAC awake. We're going to talk about all these things. Because you'll hear it in clinical and you go like, what are they talking about? Okay? So what's MAC? MAC is a concept called minimal alveolar concentration. MAC is a value that is made up so the anesthetic gases could be compared. Before MAC, people would just sort of talk about, well, this agent does this if you dial it to this number. And nobody had a predictable value to use. So it was like really comparing one agent with another as being apples and oranges. What MAC did is everything compared it down to one concept, which is called the MAC. When you apply, and the way they did this is they took experimental animals, they took mice, and they put these mice to sleep. And once they were under general anesthetic, they would change the concentration to a hit equilibration. So they knew that the FA to FI curve met. So it would sometimes take 20 minutes for it to equilibrate, more soluble agents up to 30 minutes. But they did this work. Okay? They changed the dial concentration and left it there for a while. And then they would take a stimulus, which in those days was taking a rat's or a mouse's tail and wrapping it with electrical wire and then hitting it with a certain amount of electricity in a fixed amount. When 50% of the mouse tails moved and 50 of the mouse tails did not move, that is 1 MAC. Okay, so basically they applied it to every agent that we have. If you put a MAC value of 1 to a patient, if you're a true MAC value for that individual, then 50% of the time that person will move, and 50% of the time the person will be immobile. Okay? That's what MAC is telling you. It's a percentage chance that person will not move under stimulus. And specifically what they were doing, of course, it was taking a little mouse friend here and shocking his tail. Now, to our surprise, this is not the MAC that's affecting the brain. Because when you cause stimulus to painful to some mouse's tail, what you're inducing is called a reflex arc. So it's dependent on the spinal cord. And I can tell you, if you're suppressing the spinal cord, you're suppressing the brain a heck of a lot more. Okay, so most of the time, if you're a MAC of 1, your brain is going to be pretty asleep most of the time. All right? But the flicking movement, the painful movement away from pain, just means that the reflex arc has been inhibited 50% of the time at MAC of 1. Now, every once in a while in shows, you'll see a person have a painful stimulus applied to them and then they move. And the people say, well, he's awake. No, he's alive. There's a big difference between being a dead and very deep, okay? Because if you're too deep and you cause a painful stimulus and there's no reflex action, that means the actual spinal cord is completely down. If you suppress a reflex arc that's painful like that, what happens to your autonomics? They're gone. So that person's hypotensive, not doing well. That's why. So you have to find that balance. Is somebody going to move on you under anesthesia at times? And the answer is yes. You're going to do your best because every time you dial up a MAC of 1, there's a possibility that 50% of the patients are going to move on you. But if you go to too high of a MAC and you suppress everything and that person's sensitive, what's going to happen to their blood pressure? It's a tank. So you sort of have to find the balance in these individuals. So what you're looking at is you're doing basically a mathematical formula. You're looking at a bell curve for a population. If you're at a MAC of 1, that means 50% probability that the person will move under painful stimulus. On the other hand, the other 50% will stay immobile. They won't move at all. If you want to shift the curve up and you want to knock everybody out, then you increase your MAC up to 1.3 MAC. So that's 3 standard deviations away. So just going up from 1 to 1.3 MAC means that you have a 95% confidence interval that that person's not going to move. That's pretty good. What does that mean to you? I mean, that's only a little change, 1 point to 1.3 MAC, and now you got 95% confidence interval. That means the agents are very potent. Okay, you're saturating the target tissue very quickly with this small change in concentration. On the other hand, if you drop it down by just a little bit, you can also have a lot of movement. Okay, so you have to at least try to reach 1 MAC for that individual. And if you want that person not to move at all, you need to reach at least 1.3 MAC before the surgeon makes an incision. And that's what I try to do. I try to get to, if I'm starting a case, once I get them to sleep, then I start moving to get my volatile anesthetic to hit a target range around 1.3 MAC. Now what's beautiful about it is that if you know that value, then whatever you're using, you can add together to reach that number. If I'm using sevoflurane and nitrous oxide, then I can do a combination of effects that gives me the benefits of greater vascular stability, but still reach that 1.3 MAC value that I want, and the person's not going to move with a 95% confidence interval. Okay? The benefit of the MAC is a useful measure because it mirrors the brain partial pressures. It allows comparison of potency between agents. So if I tell you what's the MAC of Sevo, the answer should be 2 out of your head. What's the MAC of halothane? 0.75. What's the MAC of isoflurane? 1.17 or 1.15, depending on which book you read. So if I turn the dial to that number, I should expect 50% of the patients not to move. That's what the benefit of it is. Okay? It's a really reliable clinical measure, and it provides a standard for experimental evaluations of different medications. If you look at the history of gases, try to spend some time with Dr. Cook. Dr. Cook actually worked with Dr. Eager over in Stanford. And they were playing with many different drugs. If you ask Dr. Cook a little bit and just get him to know him a little bit better, and it took me a long time to get to know him this well, to find out that he was doing research with a guy. Okay? He was playing with sevoflurane and desflurane when it was just coming out. It was pretty amazing. They had actually tested almost 250 different volatile anesthetics or volatile agents to get the 2 agents that eventually they put to market. You know, science is full of problems, and having this MAC value helped them decide which agent they should actually use. These are the MAC values that I expect you to memorize. You have to know these. These are not going away. As for enflurane, enflurane is almost not used in the market anymore. I won't have to worry about that. But the ones I do want you to memorize, nitrous oxide, desflurane, Sevo, isoflurane, and halothane all should be memorized. Okay? Halothane is becoming more historical. I know that. Okay? But I think it's useful to know that if you have the oil-blood partition coefficient, and then understanding how halothane works and percentage, it shows you how potent it is. So I think you do have to memorize the MAC of that. So what does affect MAC? Okay? This beautiful woman here is a redhead. Okay? Redheads are a nightmare to put to sleep. Okay? And I knew that a long time ago, because every time I put a redhead to sleep, they got me in trouble. Okay? It's just like when I dated one, it got me in trouble. So I sort of was already leery of them in the first place. Okay? So I found out when I put them under anesthesia, it was a nightmare. They would move, they would buck, they would bronchospasm, they do all sorts of funny things. So when I kept saying to people, it's like, you know, why is this happening? And nobody knew the answer. The British figured it out. The reason the British figured it out because they got a lot more people that are redheads. And they kept seeing in their clinical areas that they were having trouble. What they found out was that people that are redheads have a special thing called pheomelanin. Pheomelanin actually inhibits the volatile anesthetic action. So it takes up to 20 to 30% more gas to put these people to sleep and keeping them asleep. Okay, so if you take care of a redhead, you better use more anesthesia. It's going to take a lot more to keep them asleep. And if you do that, you're going to save yourself a lot of nightmares. Okay? The other thing that increases MAC is anything that increases brain activity. So if you have hypermetabolism going on, hyperthermia, things that you give the drug-wise that are stimulants to the brain, such as catecholamines, or you have hypernatremia. All these increase brain activity and increase your MAC. In other words, you have to increase your anesthetic to keep that person asleep. And the other thing that also affects MAC is cyclosporin, which is a little surprising to me. I'm not sure why the mechanism is, but you see that in the transplant population that you do have to use a greater MAC. A lot of people forget that, okay? And when you're doing a liver transplant patient, that's coming in for regular surgery, everybody's sort of like, oh, should I give them a little bit less anesthesia because they got this transplanted liver? No, you better crank it because they got cyclosporin going in, and it's not going to. You're going to keep the person on the bed. So make sure that medication is not being given. If it is, then you got to increase your MAC. What actually decreases your MAC is things that will decrease brain size. So as you get older, your MAC value falls, okay, considerably. It actually decreases by 6% per decade. And that's a pretty good, easy number. And the numbers that we normally use is an age of 30. That's really when MAC is at the maximum rate, okay? Except, of course, in neonates. But that's where the value for an adult is pretty much at its max. And everything after that, the MAC begins to fall. Okay? Hypothermia will also decrease your brain activity. Drug-induced decreases in CNS catecholamine levels. Preoperative medications like Versed decrease your MAC. Okay? Alpha-2 agonists like clonidine will decrease your MAC. Acute alcohol ingestion will also decrease your MAC. Pregnancy, postpartum, all those things will do. Lithium, which also alters the brain activity, depresses it, will also decrease your MAC. When you give IV lidocaine, it decreases your MAC. If you're giving opiates, but we'll talk about that, it actually affects what's called MAC bar, is also decreases your MAC. And if you induce hypoxemia, it also decreases your MAC. And you got to ask yourself, well, gosh, will you ever do this? And the answer was, I found out to my surprise after talking to Dr. Cook, is they were actually doing this all the time in the old days. They would actually give people 100% nitrous oxide with no oxygen, and the people would go to sleep real quick. Gosh, I wonder why. Okay, low PaO2, that's why, and that's how they put this number up. Okay, when that number falls, you go to sleep really quick. Yeah. Okay, so not a good idea. Your brain doesn't like being without oxygen. The other thing that you also see your MAC value decreases when your blood pressure is low. Cardiopulmonary bypass will also decrease your MAC, and so will hyponatremia. And the other thing is a medication called ketanserin that also will cause a decrease in MAC. I've never seen ketanserin, so I don't know. It's one thing that was in the book. Now, if you look at age-related MAC, here's the average group. They use a 40 to 30-year age group as your main number. That's one I want you to memorize. If you go younger in age, what happens to the MAC value? It goes up in all of them. So a little neonate is going to take a lot more anesthesia to keep him asleep. The way you think about it is there's more brain. It takes more to put them to sleep. As you get older, your brain shrinks and shrinks and shrinks. If you're in Naples and you have your typical alcoholic bunch, the alcoholic bunch starts here at 10 o'clock for cocktails. And they go usually till about 5 or 6 o'clock in the afternoon. So they're drinking all day. They do a bottle of gin per day. It's pretty amazing stuff. Okay? Well, their brain is really small. You think, well, because is it going to make it more difficult for them to go to sleep? No, it's actually much easier. There's less brain size, the easier it is to keep them asleep. So you can see your MAC value, by the time you hit 80, it's dropped significantly. Okay, so all your MAC numbers have to drop. Now what's good is that you have different what's called nomograms to help you with this. I personally think I love this one here that I just got for you. This is something that I would copy and I would take with me in clinical. And what this basically does is this is a beautiful, elegantly done study that shows you MAC values per age. Okay, what you have here is the age of the individual. You have the end expired concentration of the gas that you want to achieve, and then this is the value that you should try to achieve if you're using 67% oxygen or 70% nitrous or 50% nitrous. So how does this work? Let's say you have a 25-year-old, okay, and I want to be at 1 Mac. Okay, if I'm using 1 Mac, okay, of isoflurane, I'm going to go basically and run it across. And when I use that individual, I'm going to give him 0.5 of the actual isoflurane, and then use 60-70% nitrous oxide. So it's a really nice little nomogram to use. It gives you an idea. Most people tend to overdo it. They tend to give the patient a little bit way too much. The reason we're doing that is because most of us are trying to achieve at 1.3 Mac. That's what we're trying to, because we want to get that 95% confidence interval of the person not moving. Now, see what happens when you change the person's age. Okay? Sorry, didn't move it. Okay, so as you look at these nomograms, what I would do is I would copy these and put in my pocket so I have these. The books, the other thing you'll see it is in the clinical area, some of our anesthesia machines, you will change the age, and as you dial the anesthetic, the MAC value is given by the machine, which is also very helpful based on age. But it's based on all these algorithms that you have here. If you don't have that fancy stuff in your machine, then I pull this out and I try to use it clinically. If you look at nomograms relating age, total MAC expression expressed in MAC values, this is a really fancy graph. And when you first look at it, you're going like, what exactly is it trying to show me? Okay, here's what you do. You take the person's age, okay, and this one I made an 80-year-old patient, and then I draw a line down to hit 1 MAC, and then the next line that I'm going to create is going to go from this point here, and then it's going to be based on the agent that I want to use. In this case, I put down that I wanted to use sevoflurane. Okay, so it goes through that point, then it tells me my agent that I want to use. So I'm going to give 0.6% of the agent that I want to use. 0.5 of the agent, and that'll actually give me 1 MAC at 80 years of age. So it doesn't take very much to keep somebody at 80 years of age asleep. You're down to literally 0.5, which is a normal. What's a normal MAC of Sevo? And it's 2. Sevo's 2. So let's go back. So Sevo is really, they put in the book here 1.8, but we use usually the number 2. Well, I'll make it 2, because 1.8 to 2 is I'll accept in clinical. But so try to keep that in mind. Most of us just use the value 2. Okay? It's just easier. But 1.8 to 2 is fine, depending on which book you read. Okay? So instead of being 2, you're down to 0.5, which is a pretty significant difference at that point. Okay? That's what you use it for. That's how you can use this nomogram. I like this one. This is nice and fancy. I draw my 2 lines and sort of, it helps me figure out exactly what's going on to that individual. Okay? What doesn't affect MAC? There's no change in MAC with anesthetic metabolism. There's no change in MAC from chronic alcohol abuse. The only thing that chronic alcohol abuse will do is it'll shrink your brain, so it may decrease your MAC in that respect. But is it to make you is it increase your requirement or decrease it? The answer is no, unless it's actually changing the brain size. In women or men, it doesn't make a difference. Okay, what your MAC is. Duration of anesthesia is really questionable in the sense of MAC. Where it becomes different is in the more soluble agents like isoflurane, maybe the exception as well as halothane. Where you also see there's really no change in MAC is with the normal CO2 values between 15 and 95. As long as the PO2 is greater than 38, there's really no effect. And if the blood pressure is greater than 40, there's really no change in the MAC. Potassium has no effect on MAC, which doesn't surprise you because it's a repolarization, not the part that depolarizes the cell. And then thyroid gland dysfunction also doesn't really affect MAC. They thought at one time that thyroid medications, thyroid problems would cause change in the MAC. They found recently that it doesn't. One thing that MAC is, it's very additive. You can add things together. Okay, so volatile anesthetics can't be given at the same time, which is it's a safety device. But if you were to shut one off and turn another one on, then it's going to add while that's happening. Okay, but it won't be for very long. The 2 agents that you can add together is nitrous oxide and the volatile anesthetic. If I give you this example, 1.17 of isoforin and nitrous at 52%, and I'm a 40-year-old man. What is my MAC? 1.5. Okay? When you do the math, is isoforin's 1 MAC, because it's 1.17, and nitrous is at half its MAC, which is 104, so it's 0.5 MAC. So when you add them together, the total MAC is 1.5. Okay, so 1.5, 1 MAC tells you that 50% patients will not move. At 1.5 MAC, you're at almost 100% confidence interval that that person will not move because you're above that 1.3 MAC. Okay? Opiates and MAC. When you add opiates to something, you decrease the MAC. Okay? So in essence, you're adding your MAC value. But the problem with giving opiates is that you don't, it's not like a gas where you can know the exact number and you figure out to add it as a MAC percent, you can add the numbers together. Okay? But as a consequence, when you add opiates, you can suppress the sympathetic nervous system and cause significant hypotension. It can really enhance your hypotension, especially in old people. So you've got to be really kind of careful giving opiates to old people. Now, one thing that's important about opiates is it does have a ceiling effect when you're using MAC. So once you give a certain amount of opiates, it doesn't help you anymore. Okay? And it kind of makes sense. If you try to put somebody to sleep with just opiates, I don't care how much you give. The person may be not breathing, but they're still awake. Okay? I really freaked a student out one day. I said, I'm going to teach you something. And they go, what's that? I said, well, I'm going to teach you that a person's awake, but you can't tell. And they go, well, how are you going to do that? I said, well, I'm going to do what's called a wake-up test on a patient. You're actually doing a procedure on an individual where they were doing spinal fusions, and they want us to wake up the patient and make sure they can move their feet. So the student was with me, was freaking out. They're like, how are you going to do this? I said, watch. Shut off the vaporizer. We'd leave them the nitrous oxide running. And then we get this person spontaneously breathing while this wound is huge, all the way down their back. Okay? And then we add narcotics. So the person is breathing like 4 to 5 times per minute. Shut off the nitrous. And we tell the surgeon, we'll be awake in about 30 minutes. I say, okay, that's fine. By the time I'll be ready. Okay? So this person is breathing 4 to 5 times a minute. And now the nitrous concentration is 0. And I tell the student, I say, the patient is asleep. Make sure it looks asleep. Are they moving their head? Oh, totally asleep, right? Open your eyes, and the person opens their eyes. It's like, whoa. You think somebody's asleep because they're comfortable, but that means they can still hear you. And then we had the person move their feet. They moved their feet, okay? And while they was doing manipulation in the back, they said, okay, we're safe. Okay, off we go. And then we went back to sleep. We gave more Diprovan, and then increased our volatile anesthetic and put the person back to sleep. So narcotics themselves, no matter how much you give, that person will still be awake. You're not suppressing the GABA receptor. You're not acting on the GABA receptors. You're only working at the opiate receptors. So it makes sense that it has a ceiling effect. Now, how much is that ceiling effect going to reach? And the answer is, if you give 1.5 mics per kilo of fentanyl, that's your ceiling effect. Once you give more than 1.5 mics per kilo, you don't have any additional benefit in the sense of suppressing sympathetics in that individual. Okay, so there's really no reason to give that much more of fentanyl to that individual. The person's not going to benefit anything from it. You can decrease the MAC by as much as 50% when you hit the max. So if you give 1.5 mics per kilo of fentanyl, you're going to drop the MAC by 50%. Can you drop it beyond that? No. You can add more, but you're not going to have any more MAC decrease effect. So the best you can ever do for decreasing MAC with using narcotics is 50% most of the time. Okay? So that's what I wanted you to make sure that you understood. And that's called MAC bar. Okay? Now the difference between MAC and MAC bar, MAC is a measurement of pain, and it's a reflex arc of the spinal cord. MAC bar, the way you remember it, is you're barring autonomic response. That's what the BAR stands for. Barring autonomic response. Okay? So what you'll see is that you're testing for when an incision is made, how long for the heart rate and blood pressure to increase. Okay? If you give a MAC bar of somebody, then you will hit the point where you see no change in heart rate, no change in blood pressure when that person is cut. The MAC bar for halothane is 1.4 MAC. It's a pretty significant value. Okay? Which is, and if you look at the actual number, that's 1.4 MAC of 0.75, so you would have to dial your halothane to 1.08. Now notice that the MAC bar changes between the agents. Now, that's an interesting problem because that means that it's not a universal concept for the gas. You have to sort of measure that. SIVO is nasty in the sense that it takes a lot more MAC bar for it to be effective. The SIVO, you have to use 3.5 MAC for you to be able to control the person's autonomics. That's a heck of a large amount of volume of gas. And most of the time, what do you think is going to happen when you start doing that? The person's going to be hemodynamically a little bit unstable, to say the least. So really, when you use SIVO, you're not going to be being very effective. Now, what you can do to decrease your MAC bar is you add the narcotic. You can decrease your MAC bar quite a bit with that. Okay? Now, desferrine, you have to increase your MAC bar to 1.3 to get there. The downside to that is that you really can't be above 6% with desferrine. If you increase your desferrine up to 6% or greater, you start getting too much tachycardia and get too many problems. So to avoid that, what we do is we give narcotic. We get 50% increase in MAC bar by adding fentanyl on these individuals. And you'll see people that like desferrine are very heavy-handed with the narcotics because we're basically suppressing the autonomics with the narcotics, not with the volatile anesthetics. If you don't, then you have to be dependent on the volatile anesthetics, and by that point, you're starting to have other problems with the agent. So that's a limitation of these agents. Now, what affects MAC bar? MAC bar can be very much significantly decreased by opiates. Okay? And you get a 50% decrease in MAC bar by using 1.5 mics per kilo of fentanyl. So the MAC bar if you look at isoflurane, it's down to 0.55 MAC. If you look at the MAC bar for desferrine, you're also down to 0.4 MAC. So that's a pretty significant decrease by giving a higher dose of a narcotic. And that's, if you look at the desferrine people that are big desferrine proponents, they are very, at 1.5 mics per kilo of fentanyl almost up front. Sometimes if you ask them why they're doing it, they don't tell you. They don't understand why. It has to do with these studies that they did back in the 90s where they were giving these agents to hit that MAC bar ceiling. Yes? Yep. That's the problem with them. That's a real problem with it. Okay? And then you have your nausea vomiting rate goes up. And then they blame the nitrous oxide. It's actually, it's an opiates. And when you combine opiates with nitrous oxide, you get a bad mix. Okay? So there's some downsides to everything you do. Now, the other thing, too, I want you to understand is that the pharmaceutical companies are trying to sell an agent. And if they can get you to shut off one gas, then they can make you give double the agent. That means they double their revenue. Wouldn't you want to do that? I mean, it makes sense, right? I mean, it's a good agent, so why not just tell you that nitrous is evil? And that's what they've done. They've basically tried to make you think that nitrous oxide is a bad agent. When you look at it scientifically, it's not a bad agent. It's actually a very good agent. It's a very reliable agent. It has limitations, but don't tell me the desferrine doesn't. Don't tell me the sevoflurane doesn't either. They all do. But when you combine them together, and I'll show you the next hour, it actually has some beneficial benefits to it. So what is MAC awake? Basically, the MAC awake is the end tidal concentration of the anesthetic at which 50% of patients open their eyes. Turbo will command. It applies only to inhalational agents and is affected by adjunctive needs, age, hypothermia, and sedatives. Okay? The MAC awake tends to be a third of the 1 MAC value for volatiles, and the MAC awake tends to be 0.0635 of the MAC of nitrous oxide. What does that add up to when you actually percentage-wise? The value is usually for nitrous oxide is around 9%. If you're looking at your exhale concentration for most people at 9%, 50% of people wake up. That means that if you're younger and healthier and you're not cold, you'll wake up at 12%. If you're comfortable, not really having pain, and you're older, it may take for you to get down to 6% of nitrous oxide for you to wake up. Okay, this depends on where you're at. So in that sense, it's not completely predictable. It's not a magical number. But the magical number that you're looking for is around 9%. That's what you're looking for nitrous oxide. If you look at the different volatile anesthetics, okay, MAC ends up being at 0.4 for fluorine. As long as you have people above 0.4 of fluorine, they're asleep. And they're amnestic. They may move, but they're going to be asleep. If you use desferrine, the MAC value is actually 2.1 for MAC awake. So that's pretty high. But I can tell you, people usually get down to around 1.6 on the desferrine before they're really awake. And this value is theoretical, I think, but I've seen people not wake up at 2.1%. Nitrous oxide, on the other hand, 6.6%, is overwhelmingly a very good number. Almost everybody's awake at that value, and most of the time reality is the 50% value is around 9%. So these are the actual different ages of MAC awake, okay? And that gives you a actual value. This is very predictable. You can see that the MAC awake for different agents for desferrine is 0.359, okay, versus the MAC awake is 0.26, which is actually 2.6%. That's where they came up with these magical numbers. You can see sometimes that they show different agents, like nitrous oxide is they had 50% awake at 0.66. I've seen people wake them up more like 9% in our population if you're careful. So I think it's, but pretty much at 0.66, almost everybody's awake. So the smaller the number, that means that, well, it depends on just the agent that you're using and the solubility of the agent as well. So, but it's trying to tell you what value that you measure at the exhaled that the person's really going to be awake. Okay? And what the value you don't want to get below of. If you want to have somebody asleep, you don't want to get below that number. Okay? Like if you're using nitrous oxide, if you want to make sure that person's amnestic, some books will say as much as 50 to 60%, you have to be that high to be totally amnestic. I can tell you that I shut off the agent 15 minutes before the end of the case, and that person's down to 0.25, 0.12, and they're still asleep. Now, will they hear anything? Most likely they are hearing, but they're not really caring, so as long as you're comfortable. Okay? So it depends on what you're doing. If you're doing it at the beginning of the case, then if you're at 12% nitrous oxide, they're going to move and wake up, and they're going to hear. Versus at the end of the case, when there's still gas inside the brain and the tissue, they're not going to remember just yet. If you look at people when you pull the tube out, they're talking to you. When you're finished with the case, they're talking to you and they're going, "How you doing? I'm doing fine." They're able to carry conversation with you. But if you to make them memorize something, say to them, "Okay, memorize ball, blue, and airplane." Come back and ask them that in 15 minutes, and they're going to look at you like, "What? I don't remember you saying that." Their brain's stunned. Okay, and the more soluble the agent is, the longer that stunning period is. Okay? So it gives you a probability curve for immobility. Okay? This is the one that you use, the MAC value. Okay? But there's also a probability curve for your awake state, and it's for your, let's see if I go here. This is your awake state. Okay, this shows you the value, giving you an idea of what 50% people are awake. This is the value here that you're going to 0.3 MAC of the value. Yeah, the properties of inhalational anesthetic agents, the volatile anesthetics give you 4 properties. This is where you have to start learning. This is important too. Volatile anesthetics have 4 separate properties. They're amnestics, they're analgesics, they're areflexics, which means that the muscle relax, and they're autonomic depression. They have all 4 properties. It doesn't matter which volatile anesthetic agent you're using, all of them have somewhat of an effect in this area. It depends on the blood or the tissue blood partition coefficients to determine some of the effects of these things. On nitrous oxide, on the other hand, doesn't have all 4 effects. It only affects 3. Okay? It affects amnesia. It affects analgesia, but it only affects mild to moderate. It doesn't really control surgical pain. And it actually doesn't cause as much autonomic depression as the other agents do, but it does somewhat. The mechanisms of immobility is basically two things. The gas will affect the spinal cord and will cause the sodium channels not to be working properly, and as a consequence, the axons don't produce enough velocity to drive your electrical response to your muscles. So for that reason, it causes immobility. It can also cause it at the cortical, it doesn't require the cortical level, it just requires the reflex level. You also may actually cause inhibition in the muscle itself. We think the mechanism of immobility has to do with enhancement of inhibition of glycine receptor and depression of AMPA and NMDA receptors and sodium channels. It appears not to be due to acetylcholine receptor modulation, GABA activation, potassium channels, alpha receptors, or opiate receptors. So those are not affected by volatile anesthetics. The other channels, the one that you specifically have to look at is sodium channels. Now again, why? Who cares, right? I mean, you know that your anesthetic is going to suppress and make your muscle relax. Well, what's the benefit of that? Well, that means you can use it instead of the neuromuscular blockers. I get asked by students all the time, say, well, we're doing an appendectomy, do we need to use muscle relaxants? And I say to them, no. You got the gas. Turn it up. If you give enough gas, the person will stay immobile. Okay? So sometimes you don't need to use the gas because the neuromuscular blockers are not without complications. Now, the reason neuromuscular blockers were designed and built was because you had sick people. And when you have sick people and you try to drive them into really high MAC values to immobilize them, you kill them. So what you do is you use a muscle relaxant for that situation. So if you can't carry the person with higher concentrations of gas, then you add the neuromuscular blocker. So it is appropriate at times to do this. Okay? As your lipid membrane, remember its essential makeup of cell walls. All the anesthetics are lipid soluble. But what does that really mean? Does the anesthetic affect the lipid? And does the anesthetic affect the proteins embedded, or does the anesthetic affect the proteins embedded in the lipid? Now, the Myerton-Overton theory says that the lipid bilayer is where all the action is taking place. I think it should be a combined approach. The lipid bilayer is an important area where the actual lipid-soluble agent binds. But what it does is it causes disruption of the cell membrane and alters the protein configuration so it no longer works. The ones that are really sensitive to this appear to be sodium channels. Sodium channels don't open properly. And sodium channels are very important for what? Nerve conduction. No nerve conduction, no brain talk. Okay? And you can actually give enough volatile anesthetic to somebody that the person will go isoelectric. That's pretty impressive. That means you've given enough agent that you made all the sodium channels stop firing. Okay? So is it working at the lipid layer? I think it's a matter of mnemonics at this point, but it's really going to affect the protein channels. So what you're seeing is the gas penetrate. This is the Myerton theory. The gas penetrates, disrupts the lipid membrane, and then alters the plasticity. I think it causes lateral pressure around surrounding proteins, which then disrupts the pathways of metabolism, or in this case, sometimes it causes problems with the G proteins where they uncouple. So it disrupts the secondary messenger system function as well, which is why the autonomics are suppressed by this. Because the autonomics are what? They're G-coupled protein receptors. Okay, so if you give these inhalational anesthetics and you start disrupting that area and you don't allow cyclic AMP to reproduce, cardiac output begins to fall, and you'll see also effects in contractility and heart rate. What you see with halothane, which is a very lipid-soluble agent, you see that it is a much greater effect, and contractility of the heart is significantly suppressed with that agent. Okay, it could be also that if you take the individual cardiac myocytes, halothane in itself will inhibit the muscle from contracting by acting on the voltage-gated calcium channels. So these agents can also impair calcium release. The lipid solubility of the agent will be dependent and act as an anesthetic, but not all have this effect. And we're not sure if this is associated with protein binding. Does the temperature actually affect anesthetic potency? And the answer is yes, and this could be due to lipid stability issues. The more temperature you put on somebody, the more anesthetic it takes, because what you're doing is you're agitating the lipid membrane, and the gas is being pushed in and out instead of staying where it's at. It's actually much easier to put somebody to sleep that's hypothermic. And does barometric pressure affect anesthetic potency? And the answer is yes. If I increase your barometric pressure, you're more difficult to keep asleep. But why would that be the case? Right, you squeeze the lipid membrane. So if I put you under the ocean and try to put you to sleep, and you're being compressed, it's actually more difficult to keep you asleep. Not that that ever is going to happen, but it's something to be concerned about, possibly. This is what the Meyer-Overton theory has to show. The Meyer-Overton theory is basically talking about the oil-gas partition coefficients, okay, which is indicating to you the potency of the agent. And it follows almost a linear pattern, showing you that different oil-gas partition coefficients will tell you how potent the anesthetic agent is. Pretty nice. And everybody thought, well, it's purely lipid solubility. Well, it's a little bit more complicated than that, unfortunately. The objections to the Meyer-Overton theory is that stereoisomers have different effects. And that's a really big objection. Because stereoisomers mean that that agent's got to bind to something specific. Right? Stereoisomer makes a molecule that looks the same, but it's a mirror image of it. If you give one stereoisomer to the individual and nothing happens, that means it's lipid bound. It's still working the lipid, but nothing happens. Because most likely the medication is going lipid, but then it's binding to a protein internally. So that's why it's really not simply just lipid solubility. The non-immobilizers can also, which causes no immobilization, but amnesia is another thing that is also against this, like GABA agents. GABA agents are selective for proteins. Okay? It induces changes in membrane density and fluidity, are also objections, and then the cutoff effect, which basically is something that has to do with how much agent that you're putting into the individual. Eventually, after a certain amount, it doesn't really seem to make a difference in some individuals. So that's what's called the cutoff effect. Even with high cholesterol levels, which are membrane stabilizers, you don't really see an effect on the anesthetic itself. So this kind of also argues against this theory of just purely being to the Meyer-Overton theory. Okay. The phospholipids remember you have a lipid bilayer. They're slightly different in different people because they have different saturation or unsaturated fatty acids in them. You also have this diacylglycerol structure, which is what's called a glycerol phospholipid, or the phosphoinositides, which have different components. All these things can actually be affected partially by the volatile anesthetic. Some of these are secondary signal processes, so as a consequence, the volatile anesthetic can affect some of these things. Cholesterol is a precursor of steroid hormones. It affects membrane stability and fluidity. The more cholesterol you have in it, the more rigid your lipid membrane, but it doesn't seem to affect your anesthetic potency. And most of the time, people would believe that cholesterol should decrease your effect of the anesthetic, and that's really not been found to be the case. If you look at your vitamins, you have your some vitamins such as ADEC, which are fat-soluble vitamins, and then you have your water-soluble vitamins. And when we talk about coexisting disease, we're going to talk about how vitamin B12 and nitrous oxide can cause an inhibition of that. Okay, and that can actually cause what's called a megaloblastic anemia, and some of the pathways can also affect neuronal. It causes neurotoxicity in some people. Most likely, it's the proteins that the anesthetic is actually acting on. Okay, remember, the proteins are embedded to the lipid membrane. We already talked about this before, so I'm sort of going through this cursorily. And understand that the lipid bilayer can disrupt by the volatile anesthetic, but most likely something's binding onto this protein laterally and having the effect on the proteins. Remember, the proteins have a three-dimensional structure. The primary structure is just a sequence of amino acids. The secondary structure is the alpha or beta pleating effects that you have. And then you have, the alpha helix and the beta pleated sheets. And then you have the tertiary structure where it begins to fold itself. And then you have the quaternary structure where you have more than one protein fragment being attached to another one. The actual anesthetics most likely are affecting the actual tertiary protein structure by disrupting it. but it doesn't do it permanently. If it did it permanently, then the anesthetic would become a toxin. But the good thing about the anesthesia is it mostly comes off. It binds either partially by van der Waals reactions or hydrogen bonding, and then it comes off. So proteins and anesthetics, receptor theory, of course, you have your GABA, glycine, and NMDA. You may also get what's called ion channel compression, which is a lateral, which is, we'll say, what affects the sodium channels. So this is your sodium transporter. The volatile anesthetic comes along and gets into the lipid membrane, most likely, and then binds to the protein internally here, and then basically inhibits the action of the protein. It's most likely not coming from above in here and binding to the top, but rather binding from inside the lipid membrane. That's why the stereochemistry makes a difference, because it's actually binding to something. Okay, so that's why the myorbitin doesn't really hold up. It may also inhibit secondary messengers, which are the G-coupled protein specifically. You can actually act on there. And it also acts as an enzyme inhibitor inside the cell, possibly as well. So the good thing is that anesthetics do have structural similarities, and they can have effects that are similar. This will be explained pretty well with the ligand binding. They have a significant active site. Nitrous oxide, which is a very, very small molecule, the active site most likely is a nitrogen component binding onto whatever it's binding to. That's where, if we can actually figure out what it is binding to, then you've basically got a uniform theory for anesthesia. The anesthetic binding most likely is 3D complex. It does most likely cause conformational changes on the protein, which denatures them and activating the receptors. Some of them may actually bind to receptor surface and acting as agonists, which activate the receptor GABA, because the general anesthetics do have GABA-like effects. They do give you amnesia. It may also cause an activation of channels, especially the ion channels, which are sodium channels, which then causes electrical disruption. If you look at the ligand-oriented, it describes how the anesthetic structurally binds. It's dependent not only on the structure, but also is dependent more on the reversible bonding. If you have ionic bonding versus hydrogen bonding or van der Waals, you can see that none of these are the strong bonds. This is not a covalent bond. If you use the irreversible binding by a covalent bond, the volatile anesthetic would be a toxin. So that's what you don't want to have. The agents have to be weak enough that just form ionic bonds, hydrogen bonds, or just van der Waals forces. So if you look at the physiochemical properties standpoint of the actual inhalational anesthetics, you can use the oil-gas partition model to help you. And there is a shape similarity model as well that the people are finding. And the reason they're doing all this is to find the next anesthetic, the next great anesthetic. They've actually produced over 290 to 300 different anesthetic, volatile anesthetics, of which only 3 have actually been useful. Okay? So that shows you that we still have a long way to understand it. Once we understand the 3-dimensional structure that you're binding to internally, and if you can come up with a theory on how that works, then you can actually design the drug and use it. And that's hopefully, maybe another 30 years from now, we'll have that. What's happened, unfortunately, with anesthesia medications is the pharmaceutical companies that won't stop doing research in anesthesia. Why? It's so safe now. It is so safe compared to what it was like 30 years ago. There's really not that much more money to be made in anesthesia. So the pharmaceutical companies really have decreased the numbers of research. When I was going through my residency training, there was a pharmaceutical rep every day bringing us food, bringing us new medications to take a look at. We had mibacurium coming out. We had rocuronium coming out. It was a new agent. We had desflurane coming out. We had sevoflurane, which was just coming to the States. We didn't have propofol. Okay? All these things are now just common. And there's nothing else really coming down the market that's really that new. And it hasn't been for the last 5 or 6 years because the amount of research money that's going into it's really gone down. So I think we're going to be in for a while period before it kicks up again. Anesthetics and calcium regulation may also be important. Calcium, remember, is an extremely important secondary messenger, and it can affect many, many things if you inhibit it. Okay, remember the SR is what contains the calcium in high concentrations in muscle, both cardiac, skeletal. So if you're able to affect the calcium release, you affect, as a consequence, things like contractility, and skeletal muscle weakness will also develop. So there's a whole cascade of effect, as you can see, of all the different calcium levels that are found, the membrane receptors that are found in the different portions of the cell. I'm not going to go into them specifically. Just know that you're going to have a varied effect if the anesthetic is binding onto calcium. You can go crazy. You can sit here all day and see where all calcium is being bound. Look at all the effects of calcium, all the secondary messengers that it affects. So it's just suppressing the calcium voltage-gated channels can have significant effects in the cell. What it basically is trying to do is you're trying to take the volatile anesthetics and all the other anesthetics and make a unitary theory. I think that's way too simplistic. The way I look at anesthesia is that I look at everything and saying, which receptors am I going to bind? Which agents do I want to use? Okay? The nice thing about volatile anesthetics is that it binds to many things. Okay? The downside to it is that sometimes it binds to areas that I don't want it to bind, and it causes problems for me. So sometimes when I have an issue with a patient that's unstable, I want to select the drugs that I want to use for that individual independently. And the volatile anesthetics don't let me do that. So sometimes I have to switch over from using a volatile shotgun drug to a very specific sniper-like drug, like Diprovan, okay, which just puts you amnestic. Medication for muscle relaxation, such as rocuronium, mivacurium, whatever I'm using. Another agent that controls pain, fentanyl. Okay, versus if I do the same thing by just turning on the volatile. But sometimes it's not appropriate in certain situations to use that drug. Okay? Just like anything else. Nothing is, if anybody ever tells you there's only one way to do anesthesia, run. Okay, because they don't have a clue. There's many ways of doing anesthetic. Okay? Now, the good guy that really knows his stuff accepts that and says to you, okay, this is a better anesthetic for this patient, I believe, for this reason. And he's able to tell you all the reasons. Then it's maybe partially dogma, but he's still got some kind of thinking behind it. Okay? And then the next patient, he says, well, this one doesn't work, and we should switch to this agent. And that's what I want you to sort of understand. Which agent should you use in what situation? In conclusion, a unitary theory may not really work. And instead, understanding how anesthetics bind at the cellular level really allows you hopefully to develop better anesthetics, give you more predictable results, and hopefully offset some of the deleterious effects of the anesthetics. And I'll ask you to ask still further questions about the mechanisms of action.